week, Surfing the MASH Tsunami brings you 3 major stories from the world of steatotic liver disease. This weekend, we're bringing you each of these stories separately so you can listen over a shorter, discrete period of time. Hope you enjoy them.
For the last 5 years, MASLD stakeholders, whether manufacturers, trial sites, providers, payers, patients, or investors, have turned to surfing the MASH tsunami to keep track of drug and device development, epidemiology, public health initiatives, and practice patterns. This weekend, we are sharing the 3 main sections from our episode 9. Roger will provide more information after these notes from our sponsors.
Surfing the MASH Tsunami is sponsored by these healthcare-related organizations.
Regeneron is a leading biotechnology company that invents, develops, and commercializes life-transforming medicines for serious diseases. Founded and led by physician scientists, their unique ability to repeatedly translate science into medicine has led to numerous approved treatments and product candidates in development, most of which were homegrown in their laboratories. They are shaping the next frontier of medicine with data-powered insights from the Regeneron Genetics Center and pioneering genetic medicine platforms, enabling them to identify innovative targets and complementary approaches to potentially treat diseases like obesity and MASH.
LiverRight and the LiverRight Scanning Network. LiverRight is America's first virtual specialty clinic for liver disease, offering adults in all 50 states video appointments and helping GI practices and health systems triage and treat the swelling numbers of patients seeking MASLD and MASH testing. LiverRight offers same-week video visits and accepts insurance. For more information, contact LiverRight. That's liver then R-I-G-H-T as if one word, at www.liverright.com.
Tawazun Health, your partner in global liver health innovation. At Tawazun Health, we specialize in providing small or large-scale access to FibroScan examinations for liver health-focused early detection, clinical trials, independent research, and collaborative projects with clinicians and FibroScan providers, now in over 30 countries around the globe. As industry-leading experts, we design and deliver high-quality FibroScan services because we know that accurate, high-quality, reliable data drives better outcomes. To learn about Tawazun Health or our sister lifestyle app, mylife365.me, click the Tawazun Health link on the Surfing MASH homepage. In this conversation, Jörn Schattenberg and Roger Green join Louise Campbell as she shares her major issue for the first half of 2025. In a world with approved drugs and increasing patient motivation to manage their own care, Louise asks, if we have multiple drugs available, where are the patients that we're going to locate to start drugs or participate in further clinical trials?
Our roundtable this month, and it will only be 3 episodes, so it's kind of quasi-month, are going to be our 3 co-hosts, Jörn and Louise and me, looking back at the first half of 2025 and asking what's the most important thing that happened from where each of us sit in terms of steatotic liver disease. Why don't we dive into our episode? If you live in the States, certainly 2025 has been a fascinating year, but I think it's been a fascinating year for the liver community around the world. We've already talked about some of these things in earlier episodes, but what we're each going to do today is take a few minutes and talk about what we think from our own vantage points are the most important or interesting thing that's happened in the world of steatotic liver disease in the first 6 months of the year. And then we'll go back and talk about what we think will be the most important thing to happen in the second 6 months of the year. So, Louise, how does all this grab you? How do you make use of this in what you're doing right now or in what's being done in the UK in general?
It's about awareness. It's about, for me, it's about education of what is becoming available. But the strength for what I do is what we know now that works. And it's getting that base and understanding of lifestyle management and actually looking at in depth a little bit in the time that we have in sneaky areas that people think are normal, but actually are probably contributing to disease. So it's picking out those things for me and the work that we do, because we're talking about the physical contact of the liver at the time that we're going to be assessing it. Sometimes we have blood tests available to us. So I have an addiction clinic on Fridays, for example, in a private addiction centre. And therefore, sometimes I get those bloods, but sometimes those bloods are spurious because it's in an acute phase. And therefore, we're discussing what we see, but it's also being very, very clear. And I think when Bart and I did these sessions at EASL this year in Holland and in Amsterdam, we were very, very clear that when we talk about FibroScan, we talk about stiffness. We do not talk about this is fibrosis, this is equivalent to this, or a definitive, because you can't do that from any of these non-invasive sort of markers in that way. So you've got to talk about the other reasons that this liver could be stiff, this, and we're looking at blood tests or we're looking at that. So I think the more that we know about what's happening in the world today, the more we can put that into this could be potential treatment. These are options. But I think we've seen with resmetirom that is to do with lifestyle and adjustments, and to prove that. I don't know whether, Jörn, that will be part of the approval for Germany, that the same as the US, that you've got to have lifestyle, dietary changes, they've got to be shown at some way or another that somebody has made those and failed, or not getting the success from them that you want. So that, for me, are the key aspects. The quality of diet might change liver fat more than weight loss in certain individuals, but you look at the individual and you look at the liver. You don't look at the individual and say what the liver's going to look like. There's a bias. You can look at an individual and do a scan and more or less make that scan for some people what you want it to make. So you have to be very clear that you change and you look and you get the right traces and you get the right IQRs, and let the liver tell you its story. So we can then put that into the story of the health of the person that we're talking to. And we'll often get more time to do that, which is why it's always been hard for physicians to do that rapidly in a clinic. And you can always bet your bottom dollar when you want the rapid scan, it's going to take you 20 minutes. It's just sod's law.
And a number of very important comments, and I'm just going to come back on some of those questions. The way the label of the medications will most likely read, and that's the same in the diabetes field, is that this is in conjunction with diet and exercise. However, it is, in my view, not fair to say, well, you need to demonstrate that, otherwise you don't get the drug, because there's enough patients you'd be excluding based on a number of reasons they cannot. Food insecurity being one of them, introducing even more social injustice in this theme, to lose body weight based on diet and exercise alone. So you'd still treat them. The other comment I'd really like, Louise, is, and I've seen that in scientific papers, and I try to correct it a lot, somebody comes up to me, is stop talking about histological fibrosis stages. This is not F1 or F2. This is a patient with 10 kilopascal. Okay, this is how we're going to categorize our patients in the future. You could say significant or advanced disease or non-cirrhotic and cirrhotic, but I think that, this is at the heart of this podcast, and it cannot be emphasized more. We're not using biopsy to characterize any of these patients. We're using non-invasive tests, and it's the stiffness that determines outcome and the indications for therapies.
Roger, you might know a little bit more about the US, because is that what's happening in the US, that people are being denied treatment, or just doctors are facilitating the treatment because of that? Because I wasn't clear about how the US were managing resmetirom when people haven't ticked the FDA's box.
Okay, so to the degree that I can touch that, okay, there are a whole bunch of diseases in the U.S. and drugs in the U.S. that are characterized by having to demonstrate lack of success with diet and exercise. The labeling for statins, for example, you have to demonstrate lack of success with diet and exercise. Diabetes, lack of success with diet and exercise. So as a result, I think that's historically been more an issue of what's in a label than what's actually required. And therefore a box is fairly easy to check. It will get more complicated, at least for people whose medical care is funded by the government, as the current administration does everything that it can to deny spending money on anything for people who need it. Now, that's an overstatement, but they're already talking about taking GLP-1s off Medicaid. So first they're going to take patients off Medicaid, but then they'll make GLP-1s unavailable to those patients. And those, going back to what Jörn said, those are food insecure people. And denying them GLP-1s will be a real problem for those folks, I think. So we'll get there when we talk about my issues. But Jörn, I think that's great. I think it's a great place to start. Louise, issue of the last 6 months.
Well, I think I mentioned that on the last one, and that really was the overwhelming response for the public to being offered non-invasive testing for livers, and actually having public comment on the fact that what your liver does, how important it was, and hats off to Jose and that for getting those patients. So I looked at, I think the year as a whole for me is going to be the key, because it's looking to be this sort of a milestone year because of things that are lining up and ducks coming into a row about the care and how we look at patients. So we're getting more precision medicine. We're getting more pharmacological combination therapies. We've got more drugs coming to approval. Obviously, sema and trizepatide are not too far away, potentially for the FDA approvals, probably early next year, if not very late this year. So I think we're now in that area for me of other liver diseases or other general conditions whereby we have lots more available. But that then raises the questions of, if we have multiple drugs available, where are the patients that we're going to locate for these? If we've soaked them all up with the first drug, where are we going to find them for the second and third drugs? How are we going to find them? We talked at the steatotic liver meeting about tripling capacity for location. And well, that's not going to happen. We discussed it in the meeting. It's very little that liver units can do to really, really ramp up their capacity without long business cases for staffing. So we do, and buying more machines and looking at different models. But actually, we need specialists like myself and other nurses and the physicians in the specialist area as the patients present now. So I think for me, it is about encompassing the first part of the year as a whole and watching that progress. So when we look back, 2025 could be the milestone year as we develop further. 2024 was obviously a massive year because we had the first drug approved, but it's exciting throughout. So that's what I looked at for the first 6 months, and most of that's going to progress into the second.
So if you'd like, before we come to my issue, let's stay with your issue for the second 6 months. What do you see progression looking like?
On one hand, I see it as, in the clinical setting, as very exciting. I think we will get a lot of information from the Germans and Jörn's units and places like that as resmetirom start to be utilized. But what we may also see is companies that provide private weight loss, such drugs like Wegovy, trizepatide and things like that, moving into the fatty liver disease area because they now have a drug available. The trouble is their systems are set around weight loss, and treating MASLD and MASH in these clinics will require quite a significant change into the way they manage those patients. Because if we look at some of these programs, they do not give the level of support and care that we would want or provide for our patients. And therefore, there needs to be an awful lot of thought going into what's going to happen. So I think I'm obviously going to be looking with concern about patients and people accessing these medications out of the main clinical environment and specialist care. And I don't know how that would be configured in the German market, but we see a number of companies providing private and physicians providing private prescriptions. So word of caution, that's all I would say. And let's see how it progresses. But expert input into designing an up-ramped program is required, because it's not going to be the same as managing weight loss, and it needs an awful lot more. And I think that's my big concern over what's going to happen over the next 6 to 12 months to 24 months about as we roll out these medications, how easy they become available.
Jörn, thought about Germany?
Yeah, a rollout is mainly going to be after approval of resmetirom. So really for Europe and Germany, 2025 is the first year we have access to the data. And the way I do see it is that experts will be start treating it. It's not going to be spread out too broad in non-hepatologist clinics. So it's mostly centers of expertise. One reason for that being that pricing strategies are also designed in a way that you don't have a cheap drug here. So it's specialist hands, how to interpret the tests and set the indication. But this will slowly expand. And there's a process in the German reimbursement system where in the first year there is an assessment of the benefit of the drug for the patients. And there's a lot of things going on in that time frame. Typically, you have experts moving in, treating patients, spreading the knowledge, patients coming to ask for the drug, and reimbursement in the public healthcare system is in the end then negotiated between the payers and the companies and the government to a certain degree. But what it means is that there's a slow uptake, and it gives us a learning curve, and we'll be on I would say we're on a good way to implement these drugs to patients that will need it most. It might lead to a situation where you have more advanced patients being treated first, and that's with a liver indication for resmetirom. Now, on the obesity side of things, as Louise described, there's a lot. This is not reimbursed in the public healthcare system, and there's a lot of private use. I don't see that changing in the near future, but with the indication of advanced liver disease, this might be a different aspect.
So I guess taking an American perspective where there is a ton of private weight loss, I mean, basically bariatricians, but also private weight loss clinics and all those things. All kinds of folks are advertising that they can get you GLP-1 on television daily, hourly, by the minute. One of the things I wonder is whether people who are getting weight loss managed privately in a setting, or maybe even with physician bariatricians who are not aware of the related liver issues, are people thinking that simply by dealing with obesity they are doing enough? Do patients believe that? Do the centers that provide private weight loss support make any effort to educate their patients on the need to at least explore whether they need a separate evaluation of their livers? I don't know. What I believe, I'm mindful of when we've talked about the resmetirom trials, one of the things we've talked about is that they were somewhat agnostic to GLP-1s. You had a significant proportion of patients with GLP-1s in each trial, at least a measurable proportion, and that those results didn't seem meaningfully different than they did for the others. So if patients find a way to get their livers managed, either because the weight clinics tell them, check this out separately, or because they go to somebody capable of doing all that, kind of a multi-metabolic setting, that might work out okay. If not, I completely share your concern. There are probably a significant number of people who believe their livers are fine because they've lost weight, and that's just not necessarily
No, and
so.
I can give you, there was a young lady who came in Amsterdam, and they were on a prescription being shipped in from the UK of one of the GLP-1s. And my first question when I looked at the FibroScan was, have you lost weight recently? Because the kilopascals were over 9. They were in the 9.8 range, and it didn't quite fit. And that's how it became, on that question, that raised, yes, I get a prescription sent over to me by post, a load of needles and injections from the UK. So the conversation then led about, you're going to have to please discuss it with your GP. We are going to refer you in to see a specialist. Have a conversation with your GP. This is not one of those conversations where, oh, I'm doing this and thing. It is about, this is managing your better health for your liver. Because although there was no steatosis by FibroScan within the liver, the kilopascals were out. So therefore, probably, yes, defatted. But actually, what we do need to know is this 9.8 on the way down or on the way up? So a one-off FibroScan is not, which is why we talk about serial scans. Stephen and I used to talk about it a lot, that we should be doing these every 3 months, particularly in any of these management areas of weight loss or anything, to see where that liver is settling and what's happening to it. But we just don't have capacity in mainstream healthcare to do that. I have patients who do that. But going to your other question, a lot of the people I see who talk about weight loss medication have no understanding of its effect on the liver. And that for cirrhosis, for example, some of these medications are proven not to work, but also they're not being told that. So therefore, I'm not too sure how much aware the prescriber is of some of these medications not being suitable to prescribe with people with cirrhosis. And they purely see it as a weight loss medication. So adding in more appropriate testing for anybody going on a weight loss medication would be the first thing that I would be doing. But that is not part of any of these programs, bar liver function tests, which, as we know, the bigger your BMI and the bigger you are, the more likely you are to have normal liver function tests. So again, we're led down the wrong path because we're not using non-invasive markers that we have available to triage and treat these people better. And this is my concern. If they're not there now for weight loss, then they're going to be very difficult to change that entire tract. And if I look back at hepatitis C, Schering-Plough had the same medication used for 2 markets. One was for skin cancer, one was for hep C. So Virafir on PEG. They had 2 management budgets. They had 2 entire streams of outgoings on these 2 drugs. And in the end, the shareholder said, you've got to bring it down to 1, because why duplicate processes for the same medication in different diseases? Because that becomes very expensive to these companies. No matter how big that company is, if you're spending triple advertising a drug in 3 different markets and in 3 different things, that's a loss of income or potential and turnaround, really. So I think that's what I'm seeing on the ground. Am I big enough for having the drug? Well, let's look at other ways and then have a discussion with the doctor. So there's a general lack of knowledge from people I see either on it or thinking that they need it. But a lot of them don't want to be skinny. They just want to be metabolically and more healthy and smaller. They don't necessarily want to be a BMI of 19 or 20. So these conversations are really, really important. And it's the way that those conversations are performed, are held, which is one of my keen interests, and that whole behavioural side and the motivation and empowerment of people to know that they're not at fault in a lot of these. And it's a combination of disease processes, lifestyle, and that goes into that. So we spend a lot of time on that.
On behalf of the surfers, our guests, and our sponsors, Regeneron Pharmaceuticals, Liver Right, and Tawazun Health, thanks for joining us this week.
Please join us again next week for a series of roundtables and interviews covering major recent issues in the world of steatotic liver disease.
Until next week, stay safe, surf on, and we'll see you again on Surfing Master Tsunami Podcast. Bye-bye now.